Hello, and welcome back to Wellness Wednesday, a monthly series where experts share practical tips and techniques on topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger with the Rolfe Pancreatic Cancer Foundation, and I'll be co-moderating tonight's session with Savina Chacheva and our partners over at Cancer Wellness Center. Tonight, we're talking with Dr. Matthew Dixon, a liver and pancreas surgeon and assistant professor at Rush University Medical Center, about the disparity rates and the latest advancements in pancreatic cancer surgical practices. For our friends joining us from Cancer Wellness Center, welcome. And I wanted to share a little bit about Rolfe Pancreatic Cancer Foundation. We're a local Chicago organization with connections to some of the leading pancreatic cancer hospitals and organizations in the Midwest and beyond. Rolfe provides personal and tailored support to patients, survivors, and their families in crisis by connecting individuals with the medical experts, personalized resources, and education. We create awareness about risks and symptoms, and we fund early detection research. Our hands-on approach, or as we like to call it, boots on the ground, ensures that no one has to face this alone. So what does that look like? We personally and directly connect the patients and the families with the medical experts and specialized resources that are tailored to their specific needs. Rolfe funds research because we know that the best chance of saving lives is through early detection. And we provide ongoing education and support, like our talk tonight, to empower patients and their families to make quick decisions with confidence. You can learn more at rolfefoundation.org and connect with us through our social channels as well. We'll put links in the chat for more information and easy access. Before I hand things over to Savina, I wanted to acknowledge that today is the last day of Pancreatic Cancer Awareness Month. It's been an exciting month filled with insights and events, and a time where we celebrated all pancreatic cancer warriors and their families and shared stories about and honored all of our friends in the community who have gone too soon. In reality, it's what Rolfe does every day. The added exposure and awareness goes a long way to sharing our mission and working toward our vision, which is to live in a world without pancreatic cancer. Earlier this month, our community gathered for the first time in 3 years for Friday Night Lights of Hope. It was an incredible celebration that raised over $215,000. How incredible is that? And as we head into the end of the year, we're going to be kicking off our annual Matching for a Cure campaign, where your gift can help us unlock a $25,000 match to honor the life and the legacy of Michael Goldberg. Keep an eye on our social channels for that kickoff, and remember, every dollar counts. We'll be sharing more details about our 2023 plans in the coming weeks, but in the meantime, I'm so excited to share that Rolfe Foundation has been selected as the recipient of the Highland Park Charity Drive. It's a student-driven event where the students and teachers and staff all vote on a local organization that's making a positive impact in the community. And last year, this charity drive raised more than $96,000 for the recipient. So you can imagine we're thrilled about what the impact of this and these dollars will be on pancreatic research and the support that Rolfe provides for patients and families. So it's a local award, but everyone can participate. Funds are going to be raised throughout the month of January, and we'll be sharing more details about that as we get closer. But as the kids like to say, new merch has dropped. So we'll be sharing a link in the chat right now, and you could check out all of the cool merch just in time for the holidays. Now, I'd like to welcome my partner tonight, Savina Chacheva from Cancer Wellness Center. Welcome, Savina.
Thank you for the warm welcome, Erin. As always, it's a pleasure partnering with you and the Rolfe Pancreatic Cancer Foundation. Good evening, everyone. Thank you for joining us tonight. For those of you new to the Cancer Wellness Center, I would like to take a minute to tell you more about the Cancer Wellness Center and the services that we offer. The Cancer Wellness Center was founded in 1989 as a nonprofit organization with the mission to improve the physical and emotional well-being of those impacted by cancer and their families. Our services, which are both virtual and in person at Northbrook, include educational programs like the one this evening that aim to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, stress reduction, and more that provide a holistic approach to healthy living, and support services, including counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org. and the link will be included in the chat. Thank you.
Thank you, Sabina, and thank you and the entire Cancer Wellness team for the incredible work that you do day in and day out. So a few housekeeping items before we get started with Dr. Dixon. You can ask questions at any time throughout the session tonight. You could do it in the comment section below, in the chat. You can email us at info@rolfefoundation.org. And we'll be sure to get all of those questions together and answer those at the end of the session. So tonight we are grateful to have Dr. Matthew Dixon. He's a pancreatic and liver surgeon and a professor at Rush University Medical Center. He has a passion and an interest in the clinical treatment of patients with cancer of the liver, benign liver tumors, bile duct cancer, pancreatic cysts, neuroendocrine tumors, and other types of rare pancreatic cancer or pancreatic tumors. And we're so happy to have him join us tonight. Welcome, Dr. Dixon.
All right, thanks very much, Erin, and for that warm welcome, and thanks to the Rolfe Foundation, and thank you, Sabina, and the Cancer Wellness Center just for having me. Very excited to be here, and I'll go ahead and share my slides. Okay, so hopefully everybody can see my slides there. So the title of my talk tonight, I just want to spend some time talking about obviously a topic that I have a lot of interest in, and that's disparities in access to care for pancreatic cancer. Okay, I have no disclosures to share with you. So as a bit of an outline for the talk this evening, I'm going to spend a lot of time just going over, giving you an overview of the care of pancreas cancer and sort of where we stand in the United States today. And want to spend some time when we getting in the bulk of the talk. I'm going to spend talking about a lot about the disparities in equity and access to care, and that being from the standpoint of differences in epidemiology. Spend a little bit of time talking about some differences in biology, underutilization of multimodality treatment, which I hope to show you is really important in the treatment of pancreas cancer, underrepresentation in clinical trials and some factors that are contributing to underutilization, and trying to operationalize change, which I think is a very complex, multifactorial topic, which would really look forward to hearing from you all in terms of your thoughts about how we can do that. So, to start off, self-reported race does correlate with socioeconomic status, and in turn, low socioeconomic status can be associated with poor access to high quality care, as well as lower screening rates and delays in treatment after diagnosis, and low treatment adherence. And cancer health disparities between racial minorities and non-Hispanic whites can in part be explained by some of these associations. Furthermore, financial distress that can be associated with cancer management can prevent adequate care, and this can start prior to diagnosis, and it can occur during imaging or even just through the whole pathologic confirmation. And whereas effective advances in multidisciplinary cancer care have contributed to improved survival rates, the cost of these treatments and the concomitant impact of some of those treatments on employment, disability does disproportionately burden those patients who are socioeconomically disadvantaged, many of whom are Black patients and Hispanic patients. So we'll just kind of dive in and talk briefly about pancreas cancer, and this obviously being Pancreatic Cancer Awareness Month. I may be sharing some things that you may have heard of already, but this this slide comes from data that's published every year by the Center for Disease Control, and as you can see, for both men and women, pancreas cancer isn't really even in the top 5 in terms of new cancer cases. We are seeing certainly a rise in the incidence of pancreas cancer, but it falls well below things like lung and colon, melanoma, et cetera. But what's important here is that when it comes to talking about cancer-related deaths, pancreatic cancer is up it really kind of punches above its weight in terms of incidence when what it caused, and then the rate of cancer-related deaths that it causes. And as you can see, for both men and women, it is certainly within the top 5. This table is just drawn from a summary article from the New England Journal of Medicine. In terms of risk factors for pancreas cancer, as you can imagine, smoking is a significant contributor, longstanding diabetes, some non-hereditary and chronic pancreatitis, obesity and inactivity can be a risk factor. And interestingly, patients who do not have type O blood can also be at risk. There's also several genetic syndromes. I won't spend a lot of time going into talking about those. One that I'll highlight is hereditary breast and ovarian cancer syndrome. So the inherited breast cancer genes, BRCA and BRCA2, can be associated with increased risk of pancreas cancer. So this slide I borrowed from one of my former colleagues and really shows just how significant a problem this is becoming, and just the fact that by 2030 in the United States, pancreatic cancer will become the second most deadly cancer. So this is from an old news release, so it's about 6 years ago from CNN. But it has already surpassed breast cancer to become the third leading cancer killer in the U.S. With, for both men and women, more than 41,000 deaths. I mean, I think that's in part because breast cancer obviously disproportionately affects women, as you can imagine. Male breast cancer is very, very rare, but it's also because we have much better treatments for breast cancer than we do for pancreas cancer. And so some of the challenges with treating pancreas cancer, and Aaron shared this at the beginning of the talk, but one of the big problems is there's a real lack of any established screening tools. So for breast cancer, where we have screening mammograms, for colon cancer, we'll have screening colonoscopies. Those have really helped to reduce, or at least diagnose those cancers earlier and help reduce cancer-related mortality from those illnesses. But pancreatic cancer, unlike those, we really don't have an established screening tool that helps us to detect these cancers early. And that, of course, leads to a late appearance of symptoms. And I always tell patients that when cancers are big enough to cause symptoms, that's not a good sign, because it means those cancers can be a large size, and unfortunately, oftentimes means that it's too large for us to be able to potentially do surgery. And of course, with pancreas cancer, as we all know, this is a really aggressive cancer. There's a rapid growth of these tumors, and it likes to grow and spread, pretty fairly early. And so, we really try to think of pancreas cancer as a systemic disease, really from the outset. So this slide just comes from a summary, and as a surgeon, I tend to try to, when I'm seeing a patient with pancreatic cancer, I tend to place them in one of these 3 categories. The first one is patients who are resectable, meaning their tumors are far away from any of the blood vessels that are important. So the superior mesenteric artery, the superior mesenteric vein that you see in the diagram there, those are really important to know the relationship of these tumors to those blood vessels. And so when somebody has a resectable tumor, it means it's early stage enough that it's far away from those vessels. Patients who are, and that represents, by the way, about 20% of patients. And for patients who are borderline resectable or locally advanced or unresectable, that represents about 30% of patients. And then unfortunately, about at least half of patients with pancreatic cancer will have metastatic disease or stage 4 disease, really from the outset. And so in terms of treatment sequence, especially with talking about this first 2 group of patients who I'm certainly more likely to see in the clinic, wanted to spend some time really just talking about that treatment sequencing. And so really, regardless of surgical resectability nowadays, we put pretty much everybody on chemotherapy first, for that reason that I said, just because pancreas cancer is such an aggressive cancer. It likes to grow and spread early. And by starting with a treatment that goes all over the body, and that being chemotherapy, we start virtually everybody nowadays on chemotherapy. certainly at our center and any high volume center like Rush, all these patients are reviewed at a multidisciplinary case conference that's attended by surgeons, gastroenterologists, medical oncologists, radiation oncologists, and we all decide as a group what the best sequence of treatment will be. And invariably that does involve chemotherapy first. Sometimes it'll involve radiation, and then assessing the treatment response with the goal of trying to get those patients to surgery to take out their tumors. And that's often followed with chemotherapy again afterwards. Excuse me. So in terms of the surgical treatment, that really kind of comes in one of two flavors for pancreas cancer. The first one on the left-hand side of the screen is called a Whipple procedure, and this is the procedure that we'll do for patients who have tumors that are located in the head of the pancreas, the area called the uncinate process, or the proximal neck of the pancreas, and that involves removing part of the pancreas. It involves removing the first part of the small intestine called the duodenum, as well as the gallbladder and part of the bile duct. And then there is a reconstruction that we have to perform after getting the cancer and the whole specimen out, where we'll attach the small intestine to the pancreas, and then an attachment to the bile duct, and then lastly an attachment to between the stomach and the intestine. And then in the figure on the right, for cancers that are located in the body and the tail of the pancreas, the surgery that we'll typically do for that is called a distal pancreatectomy, and then we'll have to remove the spleen with these cases as well. So in terms of just sort of highlighting, I guess, what's new with surgical treatment, I mean, these surgical procedures have been around for a while. I think the things that are new, the two things that I'll mention that are fairly new with treating these diseases are, number one, minimally invasive surgery. So certainly in the relating to distal pancreatectomies and splenectomies, and we're pretty much, certainly at our center, we're doing almost all of those cases either robotically or laparoscopically. That's pretty routine for us nowadays, and at least 80% of those cases we're able to complete those surgeries minimally invasively. The uptake for minimally invasive Whipple procedures has been a bit slower. I have performed robotic Whipple procedures before, but I think that I'm a little bit more comfortable personally doing them open, and I tend to use robotics as a tool and not something that I try to do on everybody, and so it really does have to be kind of the right patient, right tumor to utilize the robot to do Whipple procedures. And then the other thing I guess I'll mention that's sort of new with surgery is enhanced recovery pathways after surgery for all these patients, regardless of what type of surgery they're undergoing, with the goal really of trying to do the surgery well with as few complications as possible, and getting patients out of the hospital and then back to their baseline health, so they'll be able to get back on chemotherapy, because it really is that multimodality treatment that is really important. So our goal with the Whipple procedure is trying to get patients out of the hospital between about day 5 and day 7. About 70 to 75% of patients are able to leave the hospital in that time frame. And then certainly with the distal pancreatectomies, with us being able to do those minimally invasively, most patients will leave the hospital between day 3 and day 5 after surgery. So talking a little bit about surgery, and this is older data, but there is a certain nihilism which comes to even offering surgery. And as you can see from the curve on the right hand of the screen there, this is a survival curve that really highlights the fact that patients who who have early stage pancreas cancer, as long as they can undergo surgery, they certainly have much improved survival over people who even the same stage 1 disease, if they're not offered surgery, obviously surgery can help these patients live longer. So it's really important to try to offer that when possible. And just highlighting here, this was an updated study that was done 11 years later, and shows we haven't really made a whole lot of progress. There's still a lot of patients who, even with early stage pancreas cancer, are experiencing detrimental survival compared to those who are undergoing surgery. So So to kind of move into sort of, I guess, the next phase of the talk, and really wanted to spend some time talking about the undertreatment of pancreas cancer. So, one of my residents at my prior institution, Maddie Torres, and I, and my former partner, Neeraj Gusani, we wrote a review paper that really kind of serves as the model for what I want to talk about for the remainder of the slides this evening. And looking at these 4 areas where we're really, there's a real undertreatment of pancreas cancer. So to start out with, just talking about the epidemiology of this disease. So, the reality here is that Black patients have the highest incidence of pancreatic cancer compared to other racial ethnic groups. So that's just a fact. And, compared to non-Hispanic white patients, Hispanic patients, American Indians, and Asian Pacific patients. As you can see just in bold there, Black patients do have the highest incidence of this disease. And the explanation for this disparity in incidence is unknown. It's likely multifactorial, and it appears to be related to really a variety of factors. That it could include differential rates of smoking, exposure to chemicals, alcohol use, diabetes, poverty, obesity, and then really a lot of the other subsequent, social determinants of health that can go along with that. And then, of course, as you can imagine, following with incidence, Black patients also experience the highest reported death rates from pancreatic cancer, with 13.3 deaths per 100,000 people. So with the more kind of granular examination, it does become clear that other racial group and ethnic groups also experience mortality rate disparities with pancreatic cancer, in addition to Black patients. And so that being that being Native American patients in particular, who and those patients tend to die at a higher rate within the first month after diagnosis compared to white patients, as an example. So, and then notably, however, and also likely contributing to differential mortality, is that Black patients do present more frequently with local, regional, and metastatic disease, leading to lower rates of surgical resection. As you can imagine, there's a lot of potential factors associated with that, like even just access to primary care physicians, or having any non-specific symptoms that they may be having paid attention to by their physicians. So the next one, which I briefly want to talk about, is differences in biology. This is kind of a boring slide, but I'm just sort of talking about some of the different genes. But racial differences in gene expression and some tumor inflammatory response, and then behavior in the tumor microenvironment has been shown to be different between races and other cancers. Although their significance in contributing to disparities in pancreatic cancer is unclear, it is important to mention, I think, at least their existence. The first one there, KRAS, this is mutated in over 90% of all pancreatic cancers. So, so pancreatic cancer is a very KRAS-driven type of tumor. One particular mutation of this gene, the G12V1, which I've mentioned there, we tend to see a higher rate of that in Black patients compared to white patients. It's unknown whether or not that does lead to more aggressive disease and worse survival. The second one that I mentioned there, the somatostatin subtype receptor, SSTR5. This has also been associated with regulation in pancreatic cancer tumorigenesis, or otherwise, starting to form a pancreatic cancer. There's 3 specific genotypes that have been identified. The one that I've listed there, the TC genotype, is associated with increased tumor aggression and higher risk of mortality, and that there is some evidence that shows that may be more frequently seen in Black patients compared to white patients. The next one, this molecule called CASO, which is what's called a bimodal transcription factor, helps to facilitate tumorigenesis through the suppression of different genes, and it does seem to have elevated expression in Black patients with pancreas cancer, although it's unknown whether or not that does lead to more aggressive tumors. And then lastly, this last protein KDM4 also has increased expression in black patients with pancreatic cancer, but again, not known if the potential mechanism here is not really known whether or not it is contributing to worse outcomes in pancreas cancer. So regardless of all of these, differences in biology between races, I think it's really important, to really say that, any of these previously mentioned transcription factors, receptors, mutations, et cetera, while it might be associated with an increased risk of developing pancreatic cancer, and therefore maybe explain why we see differences in incidence, sorry, I just got interrupted there. While it may explain why there's an increase in incidence, there really isn't any explanation for why there's an increase in death from pancreatic cancer. And so it's really, can't really be seen as solely responsible for the disparity in outcomes for these patients. So next, I just want to talk about underutilization of multimodality care. So, despite strong evidence supporting multimodality treatment, many Black patients are not actually offered consultation and don't receive multimodality care. And Black patients tend to experience lower rates of consultations with specialists, including consultation with a medical oncologist, a radiation oncologist, and a surgical oncologist. And these patients are also less likely to undergo chemotherapy, and they're 25% less likely to receive chemotherapy after surgery. And there's also disparities in the receipt of surgery. So, for our review, we looked at multiple studies that focused on evaluation and receipt of surgery based on race. And the majority of these studies all suggested that there is decreased offerings and receipt of surgery for Black patients. And that this, I think, is a really significant contributor to the overall low survival rates that we see. So 29% of Black patients with potentially resectable disease do not even receive surgical evaluation, and they're less likely therefore to undergo surgical resection, especially if they're not being seen by surgeons. And then when compared to white patients, Black patients were also offered less surgery at a lower rate compared to white patients. And so this has obviously translated into Black patients undergoing fewer surgical resections. And some of the factors that are associated with that include, and this is in particular from one study, so patients who are older, have higher comorbidities or like a higher number of additional medical problems, non-English speaking, Black race, low income, less education, and non-private insurance were all contributing factors that led to a decreased likelihood of undergoing surgery. And so, what that's translated to is that there are about a 38.2% of patients with resectable pancreatic cancer are not undergoing surgery. This is for Black patients, while 51.7% of patients with stage 1 disease do not even undergo surgery, just for a variety of factors as listed there. And again, non-white patients are less likely to undergo resection, and that's about, in particular with Black patients, they're about 24% less likely compared to white patients. Some of the factors that are contributing to this. One is insurance status. So there are, this for me actually. So a little background about me: I'm actually from Canada, and I grew up with a public healthcare system. And so, when I moved to the U.S., I think I was pretty naive about how much of a problem this is, and it was a little difficult for me to wrap my head around, to be honest. But the truth is, for patients with private insurance, these patients experience increased receipt of perioperative therapy compared to those patients who have Medicaid, Medicare, or they're underinsured or they're uninsured. One study in the state of Florida found that the average survival for patients with pancreatic cancer was basically inversely proportional to their poverty level. So the poorer you were, the worse that you did. It was inversely associated, pardon me, with private insurance. So in other words, if you had private insurance, then you lived longer because more of these patients ended up getting multimodality therapy, whereas obviously the poorer patients didn't have access to that multimodality therapy, and so their survival rates really suffered. So how about when we level the playing field, then what happens? There was a study that looked at that as well. And the effect of health insurance expansion in the state of Massachusetts back in 2006 found that there was increased resection rates of pancreatic cancer compared to states that didn't expand access to health insurance. However, even when we control for bad insurance or no insurance, Black patients are still receiving less surgery. They're receiving surgery at lower rates compared to non-white patients, suggesting that lack of insurance is not solely the reason that's contributing to these decreased resection rates. And also in unresectable disease, so patients who either their tumors are too advanced or they have metastatic disease, even those patients with private insurance were more likely to receive chemotherapy compared to patients without insurance. There's also maybe an implicit bias that's also at play here. I mentioned some of the nihilism that surrounds pancreatic cancer earlier in the talk, but there's also potentially an implicit bias that's at play here as well. And there was one study that we looked at that found that Black patients received less cancer information, including names and referrals to cancer specialists that specialize specifically in pancreas cancer. And furthermore, some of those physicians can be less patient-centered, provide poor quality information, and different advice when it comes to meeting Black patients. For patients with comparable disease stage, surgeons were also less likely to recommend surgery for Black patients. And that kind of ties in with some of the data that I showed before. And then patient refusal. So there can be a lot of misconceptions about cancer surgery that could drive patient refusal to want to even undergo surgery. Some of those beliefs can be mitigated by trying to practice culturally competent and patient-centered care to try to explore and address some of the concerns that patients have and the anxieties, which there's obviously always a lot when it surrounds pancreas cancer. One statistic that I found really disturbing is that Black patients are 3 times more likely than white patients to refuse surgery. And there are several studies that we looked at that found that Black patients were more likely to refuse it despite equal recommendations for surgical resection. Refusal for surgery excuse me, is associated with older age, evaluation at a non-academic program, so a non-university hospital, patients who have higher comorbidities, and should serve as no surprise, patients who have non-private insurance as well. And as you can imagine, with this disease, refusal for surgery has also been associated with refusal of other therapies like chemotherapy and radiation. Refusal for surgery, it may just be because of concerns of the surgical risk, some of the diagnostic uncertainties, but I think a big one is historical distrust in the healthcare system, which is why I kind of wanted to devote even one slide to this. And so I think this can be kind of a tricky issue to talk about, because to simply state that patient mistrust contributes to disparities in receipt of treatment among Black patients really kind of ignores the years of mistreatment, abuse, and structural racism that's really heavily embedded in the history of medicine in this country. And assertions that patient mistrust is what drives disparities will obscure the etiologies of racial health inequities and blames patients for their disproportionate suffering. This is particularly, very much true for Black patients, and any mistrust that those patients harbor toward the U.S. healthcare system is a result of their really never-ending mistreatment and not the cause of it. And I think suggesting that, trust and not structural racism is the primary barrier between Black patients and equitable care and positive healthcare outcomes is just simply not true. And, really at the end of the day, I think, if Black patients harbor mistrust towards the US healthcare system, which is a system that's really afforded them inequitable access for virtually every conceivable type of care, it really exposes their valid assessment of our healthcare system and its performance or underperformance in adequately serving them, and it's not the root cause of their poor outcomes. And so, shifting the blame to patient refusal of care due to mistrust, I think, is focusing, and not focusing on addressing the structural racism that we see causing health inequities only really perpetuates this problem and can be really quite dangerous. So next, talking about other factors contributing to underutilization. So underutilization of high volume centers. So one of the things that I should have mentioned earlier in the talk when I was talking about surgery is, it's really important to get, to try to seek out care and your surgery at a high volume center. What I mean by that are hospitals that perform these surgeries a lot. Whenever I meet patients and talking to them about treating their pancreas cancer, I'm always, try to be clear in saying that, for somebody like me who specializes in doing pancreatic cancer surgery, that doesn't mean I'm a better surgeon than surgeons at a community hospital. It just means that I'm specifically trained to do these procedures, and we do them a lot. And that's not just me; that's all the other doctors that help us take care of these patients, like our gastroenterologists, our interventional radiologists, our ICU, medical oncology, radiation oncology, et cetera. So, when you're at a center that treats this a lot, your outcomes are going to be better. And so it should probably serve as no surprise that there's been a lot of studies that have shown that regionalization of care or care at high volume centers, while it does show that there's improved outcomes for surgery as well as receipt of multimodality therapy, but it also means that there are that patients who, non-white patients, in particular Black patients, are more likely to undergo surgery. At high volume centers, are more likely to undergo surgery at low volume centers, and there is an unequal referral rate of Black and non-white patients to high volume centers. And so, one study showed that Black patients were less likely to, as I mentioned, they were less likely to receive care at a high volume center, and they're also less likely to receive surgery by a high volume surgeon. And they're more likely to receive their care at low volume hospitals by low volume surgeons. That then serves to further increase the disparity gap in outcomes and survival. And then another study saw that Black patients were less likely to receive care at high volume centers, as I mentioned previously. And so similarly, uninsured patients and those residing in zip codes with a lower population level educational attainment were also less likely to be sent to high volume centers. So, so access to care at high volume centers is really inequitable. It's something that I would love to see change, and I would be very much open to feedback to how people think that we could do that. And obviously, I think we'll have to go be sensitive to things like insurance status, et cetera. And ensuring equitable access does require addressing some of the non-medical social determinants of health as well, such as inequities in education, labor, housing markets, et cetera. So you really kind of see how disparities in healthcare outcomes really go beyond just the care itself. It really depends on what goes on outside the hospital as well. And so lastly, just briefly, I'll talk about underrepresentation in clinical trials. A pretty low number of patients who are seen in cancer centers are even enrolled in clinical trials. Only about 2 to 4% of patients are actually participate. And there is an underrepresentation of minorities in these trials, and they only comprise about 15% of patients that are enrolled in clinical trials. And that's a really significant underrepresentation. There's a real significant underrepresentation, in particular from Black patients and Hispanic patients, in addition to elderly patients. Patients who are more likely to participate in trials are patients who who are white, who have stage 4 disease, private insurance, and fewer comorbidities, and patients who live, somewhat ironically, patients who actually live farther away from hospitals are more likely to participate. So in summary, the incidence, presentation, biology, treatment opportunities, and outcomes for pancreatic cancer vary tremendously across the spectrum for patients. And then race, gender, ethnicity, geography, socioeconomic factors can affect each of these, and inequities related to any of these factors can then lead to late presentation, undertreatment, and poor outcomes. The deadly disease like pancreas cancer, these inequities are really amplified and lead to significantly worse outcomes in our most vulnerable populations. And awareness of these trends and factors that can help provide the first step toward correcting these disparities and ultimately providing just, culturally competent, and equitable care to all patients with pancreatic cancer. That's really the goal. And so, question is, where do we go from here to try to reduce health inequities for pancreas cancer? And so, one, kind of thought about operationalizing change. I know this is I think this is like an important issues, and just in trying to highlight, inequitable access to care for the medical system broadly. And this is actually some of the data from this slide comes from Dr. David Ansel, who is obviously here at Rush, and has been a giant in looking at structural racism and the effects on disparate outcomes. And so, in one article, he highlighted 3 potential strategies to try to address structural racism in healthcare, which I think is broadly applicable for all forms of equitable access to care. And I think, we can particularly use these for pancreas cancer. So number one, clinicians can make the invisible visible. And what that means is that we need to utilize data to know how outcomes at our institutions differ based on race, ethnic background, gender, insurance status, neighborhood, education level, socioeconomic status, et cetera. And measuring quality outcomes, according to these factors, will illuminate opportunities to try to mitigate inequities in care delivery that might result in outcome differences for patients. And then when differences in outcomes are found, then we as clinicians can seek and understand the social and structural factors that are at play there. Number two, healthcare organizations can engage the community in an effort to change the accepted explanatory narrative. Rather than attributing or even blaming patients for their own poor outcomes or biology or behavioral inevitability, et cetera, we need to reframe them as symptoms of a pathological social system that could be improved. And then lastly, institutions can make systemic changes to help eliminate inequitable access to care. And whether we're talking about structural racism or any other factors that produce inequitable access to care. And, one, I guess, last plug is here at Rush, one of the things that really drew me to want to practice here is that, the institution, I think, has recognized well the injustice of health disparities and how rampant inequitable, access to adequate care is in Chicago. And so our healthcare system became one of the first academic healthcare systems to make health equity a strategic priority. We really kind of shown that with a concentrated investment on health equity by establishing an Institute of Health Equity, and this was obviously done in conjunction with with BMO, with help to form that institute. And look forward to trying to partner with people like Dr. Ansel, who I mentioned, with trying to reduce things like the health inequities to access to care, in particular for pancreas cancer, like we've been talking about. So that's all I had. Really thank everybody for joining us this evening, and thanks for paying attention to my talk. And would really love to hear any questions that anybody might have.
Well, thank you for sharing this and all of the work that you're doing in this arena. It's so necessary. This is so I can't decide if it's more maddening or depressing or what. So, I truly appreciate all of the thought and efforts going within it. And everybody who is participating has a lot of questions. So I'm going to jump right in. If you do have additional questions, you can continue to send them in the chat, put them in the comments, or email them to us at info@rolfefoundation.org. So the first one is talking about the rise of occurrence of pancreatic cancer. What are you attributing that rise to?
Yeah, I think that's a great question. I think that I like anything else, it's complicated, and I think it's multifactorial. I did list that one slide that talked about things like smoking, longstanding diabetes, obesity being potential causes of seeing that increased rise. I think it also could be that people are living a little bit longer, and we're also doing a lot more things like what we call cross-sectional imaging, or getting things like a CT scan for other reasons that may actually help us get lucky and try to find these tumors at an earlier stage. So it's not there's no one kind of real easy answer to sort of pinpoint as to what is responsible for that increased incidence or that rise. What has sort of been consistent, I think, is that the death rate from pancreatic cancer has remained pretty steady. And as I think the care for a lot of cancers has gotten better, for pancreas cancer, it sort of hasn't improved very much. And I think a lot of that has to do with, I think it has improved some with our recognition that this is being aggressive cancer. We need to really use aggressive chemotherapy as well as surgery, but we don't have the repertoire of chemotherapies for pancreas cancer that we do for something like breast cancer, as an example. So that's kind of where we need to continue to do more research and try to come up with new therapeutics to try to help patients live longer.
Okay, I'm gonna stay on the cancer side of things, and we'll move into the disparity. So the next question is, what can the average person do to advocate for themselves or their loved one if they feel like their doctors aren't doing enough?
Yeah, that's a great question. And I think that, and sometimes this can be, frustrating if you're going to see, say, your primary care doctor, as an example. Pancreas cancer isn't always the first thing that's really going to be on their mind. But I think that, things like getting routine lab tests and trying to check those, oftentimes we can see some elevations in the liver function tests that can signal us to some changes that can be associated with pancreas cancer. And honestly, if you're not getting anywhere there, seeking out a second opinion, trying to go and see another physician, trying to get in with a specialist, like a gastroenterologist or somebody like myself. I think those are kind of important steps, because oftentimes it's really the family members that really can see if something's not right, and sometimes it just takes being very persistent and trying to come to an answer. So it's another one that there isn't always an easy answer to that, but I guess I would just encourage people to really, if you really think that there's something wrong and with your loved one, to really continue to try to seek out care, if that means having to go and see another doctor who you think will listen to you.
Great. Are we seeing an uptick at all in disparity going down, or is it getting worse, or is it kind of staying level?
I think it's mostly staying level. I think disparities in outcomes has been sort of a, while it's not a new concept, I think that it's something that we've known about for a while. I think really kind of being scientific about it and analyzing, those outcomes has something, I think it's something that we've been doing, really effectively, probably over the last decade or so. And that's actually kind of my real academic interest is looking at that, in particular in Chicago, to look at those disparities in access to care and try to model that over time and by area of the city. And so I think as time will go on, especially if we don't really have any, really huge policy shifts or changes, a lot of those disparities will probably continue, which for somebody like me is beyond frustrating. Because as I mentioned, kind of with my background coming from Canada, I really think that healthcare is a right, not something that should be based on your ability to pay. And I think I would really love to just see really equitable access across the board. And I think as I mentioned, I think it's a very difficult multifactorial problem that I would even be open to hearing feedback from others who are on the call if they for any ideas that they think that we need to do to try to solve that, because it really will go even beyond the healthcare itself and addressing a lot of the structural racism problems we see in our society today.
Absolutely. So are doctors in more predominantly Black communities well versed about pancreatic cancer and risks and symptoms? And I'll couch that in knowing that the disparity goes well beyond pancreatic cancer. Is it more that are they not looking for it, and so that's a piece of the puzzle too?
Yeah, I think that's a great question, and I think that for a lot of, and I think it kind of goes back to my comment about pancreas cancer not always being, with it not being the most common thing, it's not always in the front of mind, and primary care doctors are a lot of times focused on trying to manage a lot of chronic health conditions, and so I think it may be. I don't know that it's not necessarily that they're well versed, but I think, and if that's in any particular area, say in a predominantly Black community, like you mentioned, but I think that just system wide, I mean, with a lot of primary care physicians, you can't really blame them, because again, it's not the most common cancer, but it's not always the most front of mind for them. So I think that it really kind of does take, I think, being committed to trying to get to any trying the underlying problems, and maybe this comes from again family members being really persistent and trying to press their doctors to try to look for other causes of the symptoms that they think they're experiencing, especially like when like less dramatic. I mean, because you can always have patients who will become jaundiced because they've got a tumor that's blocking their bile duct. I think that can be fairly obvious. And when I say jaundice, I mean yellowing of the skin, yellowing of the eyes. But even beyond that, like a lot of nonspecific symptoms, like any weight loss or difficulty eating, those sorts of things should really prompt people to know that something's wrong.
Sure. So 2 questions based off of that. So I'd imagine from the other side of the insurance piece, doctors have to follow certain edicts, from my understanding of you can only be with a patient this long, or you have to do this or that. So I'm assuming that as a doctor, you're feeling the pressure too from that side of things.
A little bit. If I'm honest, I really try to give my patients all, like, I try to be very sure that that my patients are really comfortable and all the questions are answered when I see them. And as you can imagine, I have to tend to have some fairly heavy conversations. And that for me, I think maybe gives me a bit of the luxury too, that I can budget a little bit more time for my appointments. Because I want to really be sure that patients, when they come to see me, they leave with all their questions answered. That's not always true for a really busy primary care physician that maybe only has 15 minutes. So you're right, there certainly can be that time pressure that may inhibit their sense in thinking about any potential problems like pancreas cancer. So hopefully that answers that question. But yeah, so I think for me, I really try to give my patients all that, as much time as possible. And sometimes that means I run late. I mean, sometimes that means I'm going to be 15, 20 minutes, a half hour late with the next patient. And then it's really just because, I want to try to make sure that those patients get, have all their questions answered and they're comfortable with the plan. And I try to spend a lot of time laying out, the plan that we're going to take, because I think, one surgeon who I've always respected a lot always said that with a plan comes hope. And I think when people come in, if they have a plan in place, then they know that things will start happening as far as the care. So hopefully that answers that question.
No, it definitely does. And I always appreciate doctors who are willing to be there and listen to the questions and go through everything. So that's great that you are one of those. Talking about hope, the next question is, there's a feeling of hopelessness around systemic around systemic racism. What advice do you have for people to keep fighting?
I think for me, advice to keep fighting. I think for me, I kind of have this vision of just trying to it's kind of, for me, I think it's just one patient at a time. And sometimes, I guess trying to do my own little part not little part. I mean, sometimes it could be, when it comes to treating things like this, a big part, but I really try to, I think I look even beyond the diagnosis and trying to understand some of those social determinants of health. And, being, I think, a citizen, a community member that really tries to strive to see, equity in all in all aspects of life. And I guess I would encourage people to, to work for the betterment of their community and try to serve their neighbors and serve, and try to work towards a better, equitable society. I mean, I think that kind of starts on, the local level here in the city of Chicago, and kind of going beyond that. So that's a great question, which I wish I had a better answer for. But I can say that I think being surrounded by people, I think for me, where I'm lucky to be, in a place like here where we have a lot of people that encourage each other in this fight to try to combat structural racism. And I think a willingness to be open-minded about the things that we're getting wrong too, and that I'm getting wrong, and that when it comes to fighting that, and so I think having open ears and listening to each other, I think is really, really important. So because as I think I said, coming from Canada, I think it was very naive to a lot of the issues of structural racism, and really wanting to do what I can to combat that as a healthcare provider and as a community member.
Sure. So what's being done within the medical community to address it? For example, are there campaigns that are targeting the communities? Is there extra education at conferences, that the doctors go to? At what all is happening right now?
Yeah, no, great question. And a lot of us are trying to refine our kind of approach at the bedside to try to practice more culturally competent care. And that certainly comes through seminars, through learning from each other, through being receptive to feedback and how we can do that, and trying to be aware and accepting of everybody, of all people, regardless of race, gender, orientation, etc. And so, yeah, and so I think on a systems level, and a lot of this is really burdened on the individual centers and hospitals to try to make sure they're doing that. And I think that there are certainly institutions that are doing it better than others, and I think there's always an opportunity to learn from each other. Whether that, and I'll also even say that even at from the society level, certainly a lot of the societies that I am a part of recently has initiated committees that are focused on equity, whether that's equity within the profession or equity within the community as a whole, and with our patients. And so I think it's a complex problem that I think definitely takes all of us to fix. And I think that's where, that's why I think I've said it, I've said it a few times tonight, that a lot of those social, disparities in outcomes for pancreas cancer really kind of goes beyond just the diagnosis and really relates to social determinants of care as a whole, or sorry, social determinants of health as a whole.
For sure. And I should couch all of this in saying that I don't expect that you're going to have all the answers here. It's more that, you're in it, and to get the pulse of your thoughts combined with what's happening within the industry as well. I mean, obviously it's a bigger problem. How about, minorities not getting into clinical trials? Are there ways that we as an organization or that individuals can work to increase that opportunity?
Yeah, so I think some of that has to do with some of that trust issue, which you really cannot blame patients for, given the inequitable healthcare outcomes that they've had. And some of that has to do with being at centers that offer clinical trials and even having clinical trials available. A lot of the data that I shared really has to do with really all clinical trials, and that it does tend to transcend and involve and have indeed again multifactorial in patients who have better insurance, et cetera. But I think that the onus is also on us to make sure that we are offering that to patients when available. I think it definitely, that definitely falls on us as a medical community, and trying to, I think, make patients aware, and just the importance of that for advancing things like pancreas cancer as a whole. So.
Okay, so we have 3 more questions. And for those who need to cut out, I want to just reassure you, we are recording tonight's session, so you will be able to come back and finish it out. So the next question is, I understand about the access to insurance and doctors piece, but when they're at the doctors, why are they not being offered options and surgery?
Yeah. That's a great question, and frankly, I think that the data that I shared, I kind of found pretty shocking as well once we were really doing those reviews, and so I wish I had a great answer for that in terms of why they weren't even being offered surgery, because for myself, I can't imagine not offering surgery to a patient who I thought needed it. I really don't have a great answer for you as far as why certain patient groups will not be offered surgery, and that's just unfortunately the data, which it's very illuminating and it's shocking, and and it makes me angry. I think it makes all of us angry. I think when we see, when we see results like that.
Yeah, absolutely. So what are your recommendations on what we as an organization or individuals who are not in the Black community to be able to do and help? You're looking to us for answers, and we're looking to you. Yeah.
No, for sure, and I think it goes back to the one thing, and I think, Aaron, you stress this with what the Rolfe Foundation is trying to do is directing patients to centers of excellence and high volume centers. I think that's a huge component, and so and that's why I kind of said what I did about trying to get care at a high volume center, where if you end up going to a low volume center, maybe that's a potential reason that some of these patients are not being offered surgery. Whereas if they go to a high volume center to see a surgeon like myself who does a lot of these operations, we try to do what we can and find to get these patients to the OR. And so regardless of ability to pay, et cetera, we try to do what we can to help anybody that comes through our door. So I think that's a really important one, is having that awareness of wanting to seek out care at high volume centers. That's probably one of the biggest things that we can kind of advocate for. understandably, there's probably, there's going to be a lack of things like navigators that really kind of help, steer people towards high volume centers. And I think that's where foundations like the Rolfe Foundation can be so important with trying to get patients to high volume centers that will get them the care that they need.
Sure. Okay. And we always like to end our sessions with what are the top 3 takeaways that you want our audience to leave with tonight?
Yeah. So, I think number one, pancreatic cancer it's an aggressive cancer. It's a systemic disease. It's one that requires multimodality treatment. That's really important to adequately treating patients. When patients, or when possible, doing surgery, chemotherapy, plus or minus radiation, it's really important to try to maximize the chance of people surviving. And getting that care at a high volume center really kind of helps ensure that you're getting the standard best care possible. Number 2, there are clear disparities in the incidence of pancreatic cancer. Black patients, again, are the most likely. They are disproportionately affected the most by pancreatic cancer, as well as death rate, and they have the lowest access to multimodality care in high volume centers. And number 3, I think that the reasons for that are multifactorial. A lot of that is embedded in systemic racism. They're difficult solutions. They're difficult problems to fix with not easy solutions. I think it's going to take all of us to think of ways that we could try to do that. And, I'm certainly committed to doing that, as well as many other people who do these types of surgeries and treat this type of illness. So, and we really, want to be open-minded to listen to, the community and how we can, make sure that we can provide access to that kind of care to everybody, regardless of, ability to pay, socioeconomic status, insurance type, race, what have you.
Well, I'm glad you're out there. I could talk with you about this all day and night and then some. But I truly appreciate you sharing all this tonight with us, and the work that you're doing to help so many people and to improve lives. So thank you so much for this candid discussion on such an important topic.
No, thanks. Thanks very much, Aaron. It was great speaking with you, and thanks again to everybody who tuned in. And I had a great time. Thanks again for having me.
And I look forward to keeping up and seeing what you have coming ahead.
Absolutely. Happy to.
Thank you. And thank you to Savina and the Cancer Wellness Center for partnering with us tonight. Thank you to everybody who joined us on the call, asking such meaningful and thoughtful questions. If you are catching this on the replay, go ahead and put replay in the comments and ask your questions so that we can make sure that we get those over to Dr. Dixon and get back to you. We'll be sharing details about next month's Wellness Wednesday session soon, so you can keep an eye out on our social channels. And we're always looking for ideas for future editions. So if you have a topic or speaker, please email them to us at info@rolfefoundation.org. In the meantime, you can also listen to past Wellness Wednesday episodes on a podcast. Simply search for Wellness Wednesday or Rolfe Foundation on Apple Podcasts, Spotify, or wherever you get your podcasts. On behalf of everyone at Rolfe Pancreatic Cancer Foundation and the Cancer Wellness Center, thank you so much for joining us tonight. Until next time, I hope you stay healthy and take good care. Good night.